Assalamu alaikum, friends. Today I have one important topic for you, and I try to make it as clear and as simple as possible, and also as interested as possible. So before starting my videos, I just want to remind you regarding my videos. So why these videos are important. There are two reasons. One is they are very precise, exam oriented, and will definitely help you in preparing for your exams. Second thing is I am just covering one topic per videos. So a video of your interest, you can watch anytime. So without wasting time, I'll start my topic today with a small case. So here we have a 50-year-old patient. He had fracture of humerus 9 months back. So you just remember this 9 months here, 9 months. Okay, he was applied plaster. So he was not operated, just applied plaster for 3 months. Now he is having pain, which is not much, minimal pain. There is persistent abnormal movement. Persistent abnormal movement means there is no healing of the fracture. And patient is unable to use the distal part of limb because he is not able to stabilize the limb. So if you see the clinical picture, here the patient has the fracture. So now if you see the limb is deformed. So there is deformed, there is abnormal mobility with duration of 9 months after the fracture. So this all clinical findings direct you towards the diagnosis of non-union. Non-union is the fracture didn't united after we have given adequate time for the union. That adequate time is 9 months. So how will you define non-union? Non-union is body's inability to heal the fracture. So patient has fracture or body had the fracture, but it fails to heal it. So what is the proper definition is fracture that persists for minimum 9 months without signs of healing for last 3 months. So if there is no signs of healing for last 3 months with the fracture happening with history of 9 months, then we consider it as, or we define it as non-union. So just to have a clarification of this idea, we'll go back to our childhood tale. So if you see here, this is the race between hare and the tortoise. So what is happening here? This is the point where we have the fracture. This is the point where the fracture is going to unite. So the distance between these 2 points is how much? 9 months. So this 9 months patient has to have reached the union part. Union. This is fracture. So whether you go fast, whether you go slow, but you should reach the end destination, that is union of the fracture, by end of 9 months. So if you sleep in between for 3 months, 3 months, if you are sleeping without any progress in the union process, then we consider it as non-union. So patient should have the fracture union by end of 9 months. If there is no union by end of 9 months, or there is standstill of the union process with no signs of healing for 3 months, we consider it as non-union. So what are the causes of non-union? Basically, the most important thing is vascularity of the fracture bone. So there are few bones or few types of vascularity which are at risk. So one is the bones which are having retrograde vascularity. Few bones we have watershed areas. So retrograde vascularity means the vascularity is coming from distal and moving proximally. This is retrograde, as I mentioned here, retrograde. Second thing is watershed area. One part of the bone is nicely vascular, the other part of the bone is nicely vascular. But at the junction of these two, this area, the vascularity is compromised. So this area is called as watershed area. So either the vascularity is compromised in form of retrograde blood supply or watershed area. So if have fracture in this area, there is poor vascularity. If we have fracture in this area, there is no blood flow from distal to proximal. So patient will have non-union. So what are the bones which have retrograde blood supply? This is very important because it will be asked in your PG bits also. So scaphoid. So we deal with each fracture when we are dealing with a specific bone. Scaphoid, intracapsular neck of femur, then talus fracture, and odontoid. Odontoid is your vertebral, cervical vertebral fracture. So these are the fractures where non-union happens due to retrograde blood supply. And these are the two bones where you can have watershed area. One is distal third of the tibia and one is base of the fifth fifth metatarsal. It's a fifth metatarsal fracture, otherwise called as Jones fracture. It's true Jones fracture of this watershed area. Okay. So this is definition and the causes of, vascularity of the bones which are at risk of developing non-union. We'll move on to next slide. What are the causes of non-union? So before knowing the causes of non-union, what is the adequate atmosphere for union? Adequate union happens when? So it need the fracture and should be properly reduced. There should not be anything in between. So proper reduction is one thing. Then there should not be any interposition of soft tissue. Then vascularity should be good. And it should be stable bone. So either you apply plaster, splint, or put any implant, but bone should be very stable. And so this and there shouldn't be any infection at the fracture site. So these are the adequate atmospheric condition where fracture will unite. To recall, proper reduction, no interposition of soft tissue, vascularity should be good, fracture should be stable, and there shouldn't be any infection at the fracture site. So what happens is, if anything among this factor is affected, then patient will have increased chances or risk of developing non-union. So it goes by eye. 1, 2, 3, 4, 5. 5 eyes. One eye is infection. Second is inadequate stabilization. And third is interposition of soft tissue, inadequate reduction, inadequate vascularity. All these risk factors or all these conditions are there which are not adequate for fracture union. So these are the local factors. Systemic factor is age. So children will have proper, good union when compared to very old population. Nutrition, like vitamin D deficiency, protein deficiency, all these things. So vitamin D or protein deficiency, these are the things where vitamin C also, because collagen formation, no, vitamin C also is important risk factor for deficiencies, risk factor for developing non-union. Then systemic disorders like diabetes mellitus, chronic kidney disease, hypothyroidism, anemia, or vascular disease. Alcohol and smoking, they causes atherosclerosis and poor vascularity. Medications. So these are the important medication. Steroid, it causes non-union. Quinolones are again non-union. NSAIDs, non-union. Chemotherapy patient is on tumor lysis drugs, they are also at risk of developing non-union. So these are brief about the adequate conditions for the fracture union, the local risk factor for non-union, and a systemic risk factor for developing non-union. Then how will you classify non-union? So just concentrate on this chart. So this is the patient, classification of non-union. So we classify non-union with the presence or absence of infection. If we have infection, it is called as infected non-union. I hope I am clear till now. Then in non-infected, where there is no infection, patient is having non-union, it can be further classified by depending on vascularity. If patient may have good vascularity, patient may have poor vascularity. If poor vascularity, if patient is the non-union developing, it is called as atropic non-union. Here, the bone will go into atrophy. Among the good vascularity, we classify it by stabilization and reduction. So if we have a stabilization, poor, but reduction is good. So there will be abnormal mobility because of lack of stabilization. So it will develop a hypertrophic non-union. Hypertrophic non-union. The same way, the other counterpart is here we have stabilization good, but reduction is poor. So everything is there, but except reduction. So here it will develop oligotrophic non-union. So to name, we have four type of non-union. One is hypertrophic non-union, other is oligotropic non-union, third is atropic non-union, and fourth is infected non-union. Infected non-union. So if you remember the pathology behind this one, here stabilization, here vascularity, here here poor reduction, vascularity and infection. You can define the treatment, or you can find out what is the treatment for this one. So here is again explanation of same thing. We have hypertrophic non-union. As I told before, here reduction is good, but stabilization is bad. So inadequate stabilization. Vascularity is nice here. So good vascularity and biology. So what happens here? The callus will form, but it won't form. It won't breach the fracture. So example for this one is horse hoof or elephant foot non-union. So it appears there is here, if you see, the stabilization is poor. So there is more callus formation, but it is unable to breach. So it is of two types. One is it resembles very this one. This is called as elephant foot or horse hoof type. Okay. And atropic, as I told, here immobilization is not a problem. Here the problem is inadequate vascularity. So what happens if there is vascularity? The fracture ends will get resorbed and there is no callus formation. This is like what we have in atropic non-union. So the bone is getting resorbed and there is no callus formation. Oligotropic, as I told, there is no vascularity problem, but there is due to vascularity is adequate, but there is no reduction, inadequate reduction. So if you see here, this is the example of patient who is having oligotropic. Fracture ends are fine, vascularity is good, but the reduction is not proper. There is some gap left over after the reduction. So oligotropic non-union is vascularity is good, stabilization is good, but inadequate vascularity. Infected or septic non-union, by name it is clear that there is infection. So when there is infection, there is a microemboli by the infective material and patient will have poor vascularity. So it is combination of poor vascularity along with infection. It happens most of the time in open fractures. So what are the clinical features of non-union? As we discussed before, there is no healing of the fracture. When there is no healing of the fracture, there is persistent abnormal mobility or abnormal stability, abnormal mobility actually it is, and persistent deformity. And patient will have loss of function distal to the limb because of lack of stability. And definitely there will be a history of fracture. So there are two clinical signs you need to remember. One is abnormal mobility. So if you move at the fracture side, this will move separately and this will move separately. This is abnormal mobility. Second thing is transmission of movement. So the thing is that if it is a normal bone, it is in continuity. So if you move this fragment also need to move. But if there is a break here, so this movement is not transmitted to the distal part. So this is called as lack of transmission of movement. This is one of the clinical signs of patient who is having non-union. X-ray. What are the findings on X-ray? So X-ray finding differs as type of the fracture. As we told, if it is hypertrophic non-union, there is callus is formed but not breach. So it's like a horse hoof or elephant foot. Then in oligotropic non-union, there is callus formation, but there is no proper reduction. Then in cases of atropic non-union, the fracture ends are absorbed. Absorbed fracture end. So this is how it looks. So if there is non-union, so here there is resorption of the fracture end. If you recall, this is the watershed area which is causing non-union. So the proximal fragment is having vascularity, it is stopping here. Distal fragment is having vascularity, stopping here. So it's happening here. Then after that, what is happening is the medullary canal closes on both sides. And there is one is pencil and one is saucer. So saucer and pencil type, so it develops pseudo joint. It's called as pseudo orthosis. So in X-ray, you can just tell there is a closure of the these points you need to remember. One is there is medullary canal get obliterated. Medullary canal obliteration. This is you need to remember. Medullary canal obliteration. And second thing is there will be atrophy of the fracture ends, atrophy or hypertrophy depending on the type of fracture, and formation of pseudoarthrosis. Pseudoarthrosis. Okay. Then what are the blood tests for systemic disease like diabetic, hypothyroidism, or infections, CRP, ESR, all these things you need to do. For infection, you need to culture collect the culture from the local infected area. If you are suspecting a non-union, but you are not able to find it, like in intracapsular scaphoid fracture after fixing the fracture, so then you can do CT scan. CT scan is one of the important diagnostic tool in occult non-union where you are unable to take a decision. Like after fixing intracapsular neck of femur fracture or after fixing the scaphoid or talus fracture. So these are the investigations we do for fracture patient who is having non-union. Then move on to treatment. So we need to stabilize the fracture, then immobilize in the cast. Other things is we can give low dose ultrasound therapy locally and parathormone therapy and teriparatide in the form of teriparatide. This is medical management. So if you go by type of non-union, we can decide how what infected non-union. One is we need to control the infection. Once control the infection, then fix the fracture. Fix fracture. So this is the two things in infected. When there is poor vascularity, patient will have atropic. So in atrophic non-union, what you are supposed to do? We need to increase vascularity, and bone ends are dead, so we need to put bone graft also. Whereas if vascularity is good, like in hypertrophic, here what we need to do is we need to stabilize the fracture. We can use plate or interlocking nails or anything for stabilization. Whereas in cases of oligotropic non-union, we need to again, whatever fracture gap is there, we need to fix it with fixation is already there, but we need to do something to fill the gap. So we need to put bone graft, and sometimes we also need to do revision surgery. Okay. So in hypertrophic non-union, as I told, it is due to inadequate stability. So you need to improve the mechanical stability. We do internal fixation of it. So by augmentation with nails or plate. Okay. Then in atropic non-union, as I told, there is loss of biology. There is vascularities, the soft tissue coverage is lost. So what we need to do is we need to give vascular stimulation by using autologous bone graft. Okay. So we collect generally bone graft from iliac crust. So iliac crust or cancellous bone graft we can put in atropic non-union. Oligotropic also, both internal fixation is already there. You need to use biological stimulation in the form of bone graft. So if you see here, this is the example of atropic non-union. Here you see the gap is there, which is resorb bone and pencil thin cortices. So what we need to do here is we need to remove this part of the bone. Then we need to fill it with the bone graft and stabilize with the plate. So how will you, how will you describe it? So we need to open the fracture, then freshen the fracture end, remove fibrous tissue, remove dead tissue, that is fibrous tissue in between the fractures. So then open the medullary canals. Open medullary canal. Once you have open medullary canal, this is you have prepared the non-union and made it fresh as a fracture happened now. Then you need to fill the gap by putting bone graft. And also you need to stabilize the fracture. So step one is open the fracture. Second, we need to remove the fibrous tissue. Third is freshen the fracture ends. Fourth is you need to open the medullary canal. Once you have opened the fracture and freshened the fracture, then stabilize it. Once you have stabilized, you put the bone graft. This is the series of or steps of treatment for the patient who is having typical atropic non-union. When patient has infected nonunion, as I told in the previous slide, first infection need to be converted. So what we need to do for treating the infection was remove the loose and chronic infected hardware, do proper debridement, and stabilize the bone by external fixator. You can apply local antibiotic bead to increase the local antibiotic coverage. Once the patient is recovered from infection and all parameters like ESR, CRP, complete blood picture, everything comes normal, then you need to think of treating it properly by putting a definitive treatment. So we can either do internal fixation and bone graft for this patient, or we can continue proper external fixation. So external fixation we use for this one is Elizero. You just remember the term Elizero now. When we come for some topic of Elizero or external fixator, I'll describe it in detail for you. So this is the class for today. To just recall and summarize, there are two non-union. Non-union is the fracture which fails to unite after 9 months of fracture, or there is no progress in the fracture union for past 3 months. It is standstill. So it is called as non-union. So just remember that the just normal gestation period of human being is 9 months. So the same amount of time is required for the fracture to unite. This 9 months is asked in your practical exam also. The examiners are very fond of you to tell answer 9 months. And second thing is there are two reasons for non-union, poor vascularity. One is watershed area. Second is retrograde blood supply. The third thing is what are the causes of non-union? They are local causes and systemic. Local causes are very important. They goes by 5I. One is infection, then for soft tissue interposition of soft tissue, inadequate immobilization, inadequate fixation, and then what are the types of non-union? We have depending on infection, infective and non-infective. Among the non-infective, depending on the vascularity, poor vascularity and good vascularity. Poor vascularity, it is atropic non-union, whereas good vascularity but inadequate stabilization, hypertrophic. Inadequate reduction, it is oligotropic. The treatment for first three, which is non-infective non-union, is we need to treat accordingly in the form of either stabilization or stabilization plus biological bone grafting. Whereas in infected, we need to treat by two-stage procedure. First stage is to correct the control the infection, and second is to look for union. I hope the topic is clear. Thank you. I request you to subscribe, share, and like the channel. And if you need a specific topic, please message me in box. And if you want some improvement also, please let me know. Thank you for watching. Thank you.